Good morning and welcome to another Telehealth Immersion Program session. I'm Laura Fritchie, Program Administrator for the Digital Health Strategy team at the American Medical Association. Today we'll be hearing from 3 speakers from Mayo Clinic on what they're doing to advance digital health at their organization. Some quick background, if this is your first Telehealth Immersion Program session, the program was developed last year. It's a series of webinars, peer-to-peer sessions, and boot camps to share best practices around telehealth and ways to optimize telehealth in practice. We typically hold a new session each month. It's a self-guided curriculum, and all of our sessions are recorded and available both on our website. You can follow the QR code on the screen, as well as on our YouTube playlist if you search for Telehealth Immersion Program on YouTube. All registration links for upcoming events are also available on our events page. Our first speaker is Shira Haushin. Shira Haushin serves as the Executive Director, Division Chair for Strategy Consulting Services in the Strategy Department at Mayo Clinic. In this role, she oversees a large team of management consultants that help clients across the Mayo enterprise with strategy formulation, execution, optimization, and process improvement, analytics, and innovation. Previously, Ms. Haushin was Managing Principal of Dorsey Health Strategies, a healthcare strategy consultancy within Dorsey and Whitney. Prior to this, Ms. Haushin was the Director of Operations for Virtuwell, a digital health provider. She was previously an engagement manager at McKinsey & Co., leading healthcare and digital health strategy and operation team engagements. Ms. Haushin earned her BA in History and Hebrew from the University of Wisconsin-Madison and her JD from the University of Chicago Law School. She holds a master's certificate in health policy and management from Indiana University Bloomington. And Shira, I'll pass it to you.
Thank you. Hello, everyone. It's a pleasure to be here with you today. I appreciate the hosts and everything that was done to put this together. So thank you for having me. It might be actually deeply uncool to start with this admission, but I thought about it and I'm going to do so. I think some of you might relate. A long, long time ago, in a galaxy far, far away, I was a card-carrying member of the American Telemedicine Association, the ATA. This would be the classic digital health dork. This was about 20 or so years ago, and I remember distinctly being in a room. The room was 5 people. This was everybody who was interested in digital health, or what was called telemedicine back then. And we were talking about how digital health is coming. This is the future of healthcare. Digital health is coming. We need to be ready. I hate the circumstances that brought us to where we are today, specifically the pandemic and many of the other much more positive technology advancements. But now digital health is not only coming, it's already here and long past. We're in a different place in the conversation. So one thing that gives me solace is that before, whereas I was one of the 5 digital health dorks in the area talking about this, it is truly a pleasure for me now to be in this room with you, with many more people, bringing many more perspectives, particularly in the clinical arena, so that we can do this right and we can do well by our patients. So with that said, as I thought about what to share with you today, and I thought about the conferences and panel talks that I've attended, something that struck me is that it has been incredibly helpful to hear what works and to see firsthand in various experiences what works at different provider systems and digital health players. But I think that there's just as much to be learned from the mistakes, from the gaps, from the errors, the misses. What didn't work? And thus, what is it that you can be on the lookout for and try to avoid or at least mitigate if you run into it? So my portion of this talk is going to be a general survey with examples from a different array of healthcare providers and some digital health players and where there are opportunities. And the 3 general arenas that I'll tackle is first, when you're doing your strategy development. Second, when you're executing and acting on that strategy, the digital health strategy. And third, incorporating the perspective of the patient in a very different way than how we think about the patient in bricks and mortar. So with that, let's dive in. So first and foremost, when you think about digital health, this should be part and parcel of your strategy and your strategic planning. It should stem from your strategic goals. If you already have a strategic plan at your organization or for your department or whatever your entity is, that's just fine. But I would strongly encourage going back and pulling that out and saying, what specific goal are we aiming for? Is this about margin? And be specific and be real. Is this about margins? Is this about new patients? Is this about improving the patient experience? Is this about improving the clinician experience? If you say all of the above, you have not prioritized. So instead it would be, if we can achieve one thing with our digital health initiatives, probably a collection thereof, what would that be? What would our secondary goal be? And stay very, very tightly focused. An issue that I see across the board is a lot of organizations said that they want to address 3 or more different goals, and they end up not actually achieving any of them because there's a lack of focus and an inability to have resources across all of them. The other thing that's really important is to be very real and specific across the board and message across the board where you want to play on the spectrum of the different technology. I included just a general spectrum here on the slide. The idea is that you can run anywhere from digitizing existing processes to developing new processes to something that's transformative. People throw around the word transformative, but transformative is actually where there's something really new about the patient experience as a result of digital health. I'll give you an example. Back when Second Life was in its first life, this was at least 10, 15 years ago or so, we found, it was really interesting actually, that patients would present differently and have different therapeutic outcomes when they did mental health visits within Second Life in the virtual world than they did when presenting to the same clinician in real life. Specifically, and there was a very prominent example in the research, a paralyzed patient who presented and shared things differently in real life had a very different experience and had much better and positive outcomes when he was able to fly. His avatar was able to fly within Second Life. And so the actual experience changed something about the outcome. The challenge is everybody wants to say, well, I want to be on the far right and be transformative, but it's incredibly hard in the healthcare industry. Aside from transformation being hard in any arena, you have the ethos of do no harm to the patient, and that carries over from the clinical into the business decisions. You have a really patchwork regulatory scheme. I could spend an hour talking just about that in the digital health arena. And you have data and security concerns with respect to the patient. So it makes it hard. So if nothing else, I want to assure you, anywhere on the spectrum is fine. Just be real about it and what you're aiming to achieve. One healthcare system that I worked with and had the pleasure of working with, the C-suite wanted to be on the far right and said, we want something bold and transformative, and this will change how we deliver care. The board said the middle. They said, let's digitize and create some new processes in how we address things and make things a bit better for the clinicians and the patients. The operational leaders and the clinicians were thinking on the left. How do we digitize our existing processes and improve access and improve experience? So guess which one won? The far left. So unless it's really specific and consistent between all the different areas of your organization as to where on the spectrum you sit, and I would call it out specifically, and unless you tie this to your strategic goals, you'll end up being stymied. It's quite a lot of headache and resource spent. So the things that I would think about to address this is, first and foremost, be really specific about those goals, as I mentioned. Sort out the business model early and often. So if you say that it's about increasing margins, actually play out how that will actually happen. Ensure that your costs won't exceed your revenue. Talk about where the revenue actually comes in. Check this with the stakeholders at the conceptual stage. Also include experts earlier on. I think a lot of times digital health is shunted into clinical informatics and IT, which is indeed the province of some of the experts in how you think about it. But you have to include the clinical champions, you have to include your legal and your regulatory, and you have to include your operational experts at the conceptual stage. Or if you're past the concept stage, pull them in as early as possible. Last but not least, another tip would be to pressure test this with respect to the patient experience. So once you've landed on what your goals are and what your digital health tools will likely be and the business model, I would bring in people who have the patient perspective. It could be patients themselves, product owners, consumer experience experts, and just double check that this will work. And we'll talk a little bit more about this in the upcoming slide. So let's talk a little bit about the execution and how you enact your digital health suite of tools. There's 3 different areas to pay attention to with respect to gaps that can arise. They are aggregation, integration, and activation. Aggregation is the process of pulling together lots of different data sets and what you do with them. A lot of times it can be the analysis that goes along with it. Integration is incorporating your digital health tools or data sets into the clinical workflow and into the patient journey so that it's integrated into the course of someone's day or pathway. Activation is the one I'll focus the most on, which is what do you do about those insights? And I would argue is likely the most important. So where are some gaps that we see? These are taken again from some different examples. First, I would argue with respect to aggregation, do be sure this is not new. It just tends to be overlooked or again siloed into different areas to leverage that non-clinical data. I think social determinants is actually an excellent example where you see different departments or different initiatives or different programs with different hospital systems that might relate to social determinants of health. There's population health initiatives. There are separate and apart from this, but EID initiatives that all have actually incredibly powerful insights and programs that truly affect patients' health, but they're separate from the digital health talks that happen. And this is a shame, because if we're really talking about patient outcomes, those programs, the leaders of those programs, the patients affected by those programs should be a part of the discussion around, all right, what are our goals? How will we achieve those? And they can actually inform some of those decisions if you're talking about impacting certain populations. Genomic health is another one. Genomic data is one that I would think about and avoid siloization, in the sense that a lot of times providers currently are using vendors for either the data or for the analysis for the AI, and then working and doing a lot of incredible work to integrate that into the EHR. The problem is, by dint of that, you end up with only a specific subset, a specific department or clinical area that has access to that. And I think that that will end up being short-sighted, because as the uses for the genomic data proliferates, you're going to need to have everybody having access to that. So make sure to plan for that at the outset. One thing to also think about would be, if you can get data from outside vendors, be sure that it is complete and consistent with the workflow. This actually ties to the next major point that we'll talk about, which is integration. So integration is how we think about actually the clinician moving through the workflow and encountering the prompt or the AI insight or the image or the scan. This is where your process engineers, your ops experts, your industrial engineers really shine. You should hire and retain and really reward those folks, because they're going to be the key in terms of whether or not this is used. The thing I always tell different folks that I've worked with in the past is beware the clip and beware the clicks. Beware the clip relates to the fact that a lot of times when you work with different vendors, or even in homegrown solutions, digital health solutions, the answer, the image, the lab result, the AI insight can be delivered as a paperclip, as an attachment. It could even be separately in a different program. But when it is in that form, it means it's not discrete data that's able to be used in other methods that you'll need down the road. So what I always advise is whoever is working on implementing this, whether it's a vendor or an internal IT team, ask them where this will show up. This is, if you're a clinician, say, okay, where in chart review is this? If you're a business administrator, the same thing. You should be just as interested, because if you can't use that data unless you pull it up as an attachment, it's going to have very limited use for you later. Similarly with the clicks, every individual click that it takes for a provider to do something to access a result, an insight, reduces the likelihood that the digital health tool or data will be used. This is a known fact. You as clinicians, the clinicians in the crowd can appreciate a lot of times you're doing your charting on your own time. It's additional time, and every additional click is time taken away and reduces the usage of the tool. So it is something to watch out for. I think in particular, this is where integration in the technical area, like paying attention to site-specific context and to interoperability is key. Virtual reality and augmented reality are some really exciting arenas for a lot of providers and digital health players. But if you don't pay attention to the context, for example, a rural area in your state, the telecom connectivity, it can render all of it pretty moot. So do definitely pay attention to your industrial engineers, your IT, and make sure to get clinical input as you work through your actual integration and your execution of your digital health tools. The one that I'd love for folks to pay the most attention to upon leaving this talk, at least from my area, is activation. And by that, I mean how we actually think about transmitting this information and interacting with the patient as a result of the digital health related insight. Let me tell you a story about a hospital system that did a lot of things right. So they had determined that within their catchment area, food security was a real issue and very much related to healthcare outcomes for the patients. So they did some really nifty work with an outside vendor and some AI analytical tools to determine which patients might be most likely to have food security. This interacted with things like, for example, the patient's specific healthcare profile, when they needed to pay the most attention. So the data and the data aggregation and the analytical piece, done, check. They also did some really incredible work thinking about the workflow and how that information, which was coming in from an outside vendor as well, would come to the clinician. They had food bags assembled. They were culturally sensitive food bags. They had a script for the provider to use that was neutral and made it a part of the workflow. So integration, check, also check. So they went into this with a lot of excitement for how this would help their patients. Bags taken, nearly zero. they sat unused. And so it could have been very easy to blame the data or to blame the tool and say, you know what, this was off target, the data is wrong, we don't need this. It would be equally easy to say it's just not working with the workflow. But actually, when the CEO and the various leaders sat down, and I really want to give them credit, they said, this isn't working, let's examine why and figure out what we do about it rather than jettison it whole. They found that at the end of the day, and we should all remember this when we talk about workflow, people are people. And by that, I mean, if somebody turns to you and in person is looking right at you and says, hey, do you have, this is a part of our screening, do you have enough food at home? And that patient, oftentimes with their child sitting there with them, and even if not, still looking right at you says, no, I don't. The likelihood of that is pretty much next to nil. So when they did some digging and found that, what they did was actually a very simple tweak. They changed it to be a form that the patient filled out as part of intake. They didn't have to look at somebody. It was a checkbox. It was seen as part of a flow, but the patient didn't have to look at someone and say, I don't have enough food. The result? 30% uptick within 2 weeks, and they've continued to make ongoing improvements to the program. So the data was right, the workflow was right, the activation and how they integrated, how they acted with the patient was off, and a simple tweak made all the difference. Another example is I worked once with a really exciting digital health platform. This was actually overseas. It was related to strokes. It was a diagnostic tool, AI informed, and it could not only parse between different types of stroke incidents, but also really backed up the predictive power as to what you could do. And so they were working with a stroke network to help different hospital systems determine where patients should go. It was really exciting for the full stroke network. They were stymied. Why? Not the tool, not the process, but the actual logistics. There weren't enough ambulances and transport to actually execute on the plan. And that wasn't discovered until really, really late in the game. So when you talk about your business model and you talk about modeling things all the way through, you've got to think about what happens after the insight is delivered to the clinician. What are all the other adjacencies that are around this that will help make this go? At the end of the day, the effective presentation of the information to the patient, the logistics that surround delivering that is going to trump the availability and the accuracy of the data every time. So let's talk a little bit about the complicating factors. This is the last theme, which is simply the fact that patients arrive into digital health, as it were, wearing two hats and in a way that they don't in person. They come as patients and they come as consumers. This is a known thing, but the gap is that we know it as providers, as different players in the healthcare arena, and yet we don't plan for it. We don't actually map that out. So I would encourage you to do so. Let me give you an example. Within a virtual care visit, this is also a known thing. Patients will become impatient, this is the consumer hat, if they wait for more than 30 seconds in a virtual waiting room, that time between when you open the virtual visit and when you're seen by the clinician. This is wildly different from when you act as more of a patient in the bricks and mortar sense. You drive to a provider, you wait in the waiting room, you're roomed, you wait some more. You could wait anywhere from 15 to 45 minutes, depending on the workflow in a given place, and you don't have the same impatience or behavior that you do as a consumer in the consumer mindset in the virtual world. This is going to become increasingly important to recognize and pay attention to how the patient might behave as we start to really integrate all of the virtual visits that everyone really jumped into during the pandemic with your real life visits and the interplay between those. Healthcare is wildly different than purchasing a laptop. I included that very absurd statement because sometimes it's not that absurd when you think about the patient in these two different senses. On the one hand, healthcare is a public good. It's intensely personal in its nature. There's privacy that you expect, and there's certain things that you expect of your provider. On the other hand, in the virtual visit, you have people that want click, 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 script, and referral or whatever it is needed. It's a much more consumer mentality. And that's something that can really chafe with different healthcare providers. If you think about it, the joy, and I noted this even as I was pulling photos for this presentation, we derive joy in interacting with each other. The photos of people interacting with people are all smiling. When we think about data and insights, it's more intent and thinking about how we do it. So if we really want to affect healthcare outcomes and that connection, we need to really plan for our digital tools in ways that promote that connection. And so when to tie this back to the beginning, when you're thinking about your specific goals, and you're mapping out what the business model is, and you're mapping out, okay, what's the flow from beginning to end? What are the adjacencies? I would also include all along that pathway in which hat is the patient. Are they thinking and probably behaving as a patient? Will they have consumer-like expectations? Can we meet those expectations at each point in the pathway? So this is where the tools of product developers, human-centered design, pulling in feedback from the patient, these are all incredibly helpful at this point. So these are not all of the gaps that necessarily exist, but there are 3 areas in which I see these gaps occur most prominently across lots of different healthcare systems and different types of digital players. So if you're thinking about the takeaways, first, be really specific and realistic and context specific, location specific about your goals, and ensure that digital health is part and parcel and stems from your strategic goals. Second, adopt an ecosystem perspective with respect to those digital tools and map out everything, including the what happens next after your clinicians have the digital insight to ensure that this is actually something that's usable. And third, attend to your patient both when they are acting as a patient and as a consumer, because both of those things happen at once in the digital health arena. I hope this is helpful, and I wish you very well on your digital health journey. So with that, I will pass it on to my colleague, Amanda.
Amanda currently holds the position of Division Chair, Research, Innovation, and Translation. In this role, she serves as Administrative Partner to the Department of Medicine, Physician, and Scientific Leadership, driving the research, innovation, and commercialization strategy and aligning to the strategic priorities of Mayo Clinic. Prior to joining Mayo Clinic in 2014, Amanda worked as a product development engineer for IBM Systems and Technology Group. Amanda holds more than 25 U.S. patents and was named a master inventor by IBM for her contributions to IBM's licensed patent portfolio. Amanda earned a Bachelor of Science degree in Mechanical Engineering from the University of Iowa and a master's degree in Business Administration from the University of Minnesota Duluth. I'll pass it to you, Amanda.
All right, thank you so much, Laura. Again, it's such a privilege to be here today and share the journey that we've all been experiencing within Mayo Clinic and with the partners that we've had throughout this evolution. And today I'd like to delve a little bit deeper into a specific example that we are seeing here within research at Mayo Clinic. So what I'm going to be talking about today is the multimodal data element of medical research and essentially really harnessing what we call the insights that address the unmet patient needs. So when we talk about research innovation and accelerating that work, we're really talking about 6 different elements. We're talking about groundbreaking discovery, whether that's cellular work, preclinical work. We're talking about clinical trials. We're talking about harnessing artificial intelligence. And when I say that, I mean it as artificial intelligence as a tool itself, as well as the mechanisms within artificial intelligence to give us the insights we are seeking. We're looking at technology development, and that can be anything from new imaging modalities, it can be device development, surgical methods of development, etc. We're talking about a commercialization and partnerships. And then finally, with the ultimate goal is to be developing novel therapeutics and advanced diagnostics. And I wanted to set that groundwork for you today, because as we think about research innovation at Mayo Clinic, these are really our North Stars, these are our guiding principles. And when we're thinking about the data to help us move forward, we're really leveraging data in a lot of these different domains. Now, Shira mentioned the workflow and that the workflow is important. And when we're thinking about our researchers, and particularly our clinician researchers, delivering new insights to the patients to meet those patients' unmet needs, we're really looking at the ultimate goal of delivering these insights into the EHR and delivering these insights into the patient experience with the provider. However, the EHR is just one element of a multifaceted ecosystem of data and information. As I say here on the slide, we have information coming from a lot of different elements, from labs, from imaging, omics data, through different, genomics types of insights, wearables, telemetry, looking at clinical trials eligibility, and also outcomes. And so when we're looking at all of that, again, the EHR is just one element of that multifaceted ecosystem. And as Shira highlighted in some of her examples, oftentimes what we find is that this information or data is coming at us in many different modalities, and in many different contexts. Much of it at this point is really quite static and not integrated into the EHR. So what I'll be sharing with you today is a discovery that we are embarking on to pull this type of data in and to give it the insights that are currently actually unseen. So we have a project that we are working on within Mayo Clinic that has its elements along the digital twin paradigm. And in fact, there are pockets of this type of work happening throughout the ecosystem internally to Mayo Clinic. And I'll be talking to you a little bit about one specific example today. And I wanted to share with you the flow of data that we are doing on this journey, and it is here on the screen. So what we're doing is we're pulling data from the patient and from the Internet of Things, the IoT. We have examples of where we're pulling wearable data. We have examples of where we're pulling imaging data. The particular example that I'll be sharing with you today is pulling things from labs as well as omics data. And at this point, what we're doing is we're pulling all of that data in and aggregating it, cleaning it, normalizing it, to then feed into some decision support models for our physicians. For those of you in the audience today that use decision support methodology, this is obviously not a new paradigm at all, but what we're trying to do is make sure that the decision support methods that we're using are much more rich and actually are a learning algorithm over time. And where we are in the journey right now is that we are in the digitization phase. And Shira mentioned earlier in the timeline of maturity that first you digitize processes, then you add some elements of sophistication to that to really pull you to that ultimate goal. We're in the phase of digitization and validation at this point. And then if we move from 3 to 4, our goal here is to provide these data insights and to do some correction, some refinement, and some analytics. And we're partnering with our clinician colleagues for this. So if you look at Node 4 on this particular slide, who do we have at the table? We have data scientists, we have engineers, we have folks that are partners outside of our organization, and then we have clinicians as well. So it's really everybody at the table looking at this data and saying, okay, did the model tell us what we expected? And is the model telling us what we want it to tell us? And then we have a bifurcation of opportunity here. The particular example that I'm most intimate with right now is building out Huron Insights into ultimately an augmented reality space, leveraging the EHR, but also using the technology for patient education and for decision support that is actually a learning model for our physicians. The 5A, the other bifurcation, is where we're branching out into population insights. And so what we're really excited about with this particular bifurcation of the model and methodology is that we're not talking about using this data for specific patient insights, but instead telling us prediction of an overall population to extrapolate and scale. Now, the example that we're working through currently within our team is incredibly non-trivial. I really, kind of whizzed through that last slide, and particularly the pulling data from the patient and the Internet of Things and moving it into data aggregation, cleaning, and normalization is incredibly, incredibly non-trivial. So the use case that we have currently is where our physicians are pulling genetic data that is actually coming in from the outside in PDF format. And what we're needing to do is figure out how to digitize that information, how to normalize that, and put it into an integration engine so that it then can go into the EHR and be consumed. This genetic data is also being coupled with lab data. And our patient population gets lab data internally to our ecosystem, as well as data that is coming from the outside. Again, that data is not at a state right now where it can be easily ingested into the EHR. So what we have is an overall project that is an integration engine to pull that data in, pull out the discrete elements, and then put context around the non-discrete elements, again, to feed insights into the EHR. None of this is a trivial undertaking at all. We have an army of IT and digital health colleagues that are working through this. And then what we're doing is we're putting use cases against this to say, all right, is this something that is giving us what we need in the end. As Laura mentioned, my background is in engineering and product development prior to coming to Mayo Clinic. And one of the most ideal elements of the engineering discipline and the design process is making sure that the model that you have and the model that you're creating actually gives you results on the back end that you're expecting. You have to have a high level of confidence in the model. It needs to be tested inside and out. And so we take that methodology and put it into this integration engine work that we're doing to make sure, again, that it provides the insights that we are expecting and that we can also gain additional insights from that. Now, the world that I live in within Mayo Clinic is in the research shield of Mayo. And what we try to do is also make sure that as we are developing methodologies that then, of course, they are backed by clinical trials and validation as well. So in addition to delivering this work to the practice, we are also developing the research methodology so that we can provide the insights at the level of confidence that we need. Now, what are the current challenges? And I did highlight some of these already, but the clinical and information integration questions are incredibly sophisticated. And right now, those questions are outpacing what our current systems and automation can produce for us. How are we getting around that? Well, we're working in pilot projects and stress testing our IT infrastructure to then go to the limits and the acceleration that we need from a clinical use case. We're also partnering with other vendors and pulling out insights and teams internally. So it's really a whole ecosystem that's trying to catch up, if you will, to the clinical and information integration questions that we have. We're working very swiftly in machine learning algorithms that are advancing our ingestion of this data, the validation, correlation, and insights. Again, moving as quickly as we can to catch up to the level of sophistication that our clinicians are craving and needing. With that, context absolutely matters. So having clinicians and providers on board with us as we build these tools, as we validate them, and looking not at just the discrete data, but what are the nuances and what does the context really tell us? And it's not until the clinician signs off on these types of models that we feel confident that it is something that we can continue to roll out. And then finally, data diversity matters as well. And this goes back to our roots in clinical trials design, diversity design, making sure that our population is broad and diverse and in ingesting of data. Because if we were to build a model that was based on data that was too narrow, too discrete, or too biased, then the outcomes would be as well, and it would not be scalable to a greater audience. So finally, as we are moving forward in the use cases that we are doing internally right now, we're keeping the following next steps in mind. We're trying all of this out through pilot projects, and they're very light and very scalable by design. We're trying to de-risk these pilot projects and these algorithms in a small vantage point, and then looking for scalability. So as we're selecting projects, we're selecting projects that have a clinical question, but also projects that we know can then scale to other sister organizations, sister disease groups, sister technologies. As I mentioned, we have multifunctional teams at the table, and they are helping create these model systems. So we're really pulling from an ecosystem of talent and experience as we build this out. Pragmatic clinical trials are also essential to our strategy. And for those of you who may not be familiar with that term, what pragmatic clinical trials means is it's real world data. So what can we do to try these algorithms out, bounce it against real world data, and then tell us insights and tell us our level of confidence. All of that is part of the stress test of this design of this design process. And we have a very agile design methodology built in to our our culture here. So we're constantly stress testing this, and then once we start to see things that may not be giving us the insights that we need, we're halting, we're backing up, and then we're iterating again. So very much the engineering design principles. And then finally, Shira shared with you some of our recommendations. One of the recommendations that I would give to you is building out embedded AI talent. We have tried different models where we have AI teams that sit outside of our clinical areas or our research areas, and we've had models where the AI talent sits within. What we're finding is really more of a hub and spoke model is really starting to give us the traction that we need. So the AI talent that we're bringing in, we're now starting to embed within our departments and in our areas of excellence. And then they have a tie-in to the overall greater AI teams within our organization, but they do have the contextual knowledge of the disease groups, of the clinicians' challenges, and really bring that contextual view to bear. So with that, I just want to thank you for your attention and time today. And we just wanted to share with you some examples of what we're trying here. And in full disclosure, we're learning from the examples that we're doing very much live stream and trying to improve upon them. With that, I'll pass it to my colleague, Edwina.
Thank you, Amanda. Edwina Beskron joined the Mayo Clinic in May of 2021 as the Chief Nursing Informatics Officer. In December 2021, Edwina assumed additional oversight of clinical systems. Combining these two roles, Edwina serves as the organization's inaugural Chief Clinical Systems and Informatics Officer. Prior to coming to Mayo Clinic, Edwina served as the System Director, Nursing Informatics for Health. In this role, she led the Epic Informatics responsibilities across 5 divisions with over 400 acute and ambulatory sites. Her past experience includes being part of the Cleveland Clinic Abu Dhabi IT executive team, and she has experience working across the healthcare IT domain as a consultant, vendor, and healthcare provider. Her clinical background includes gynecological oncology and medical surgical nursing at Johns Hopkins and the University of Pennsylvania hospitals. Edwina, I'll pass it to you. Thank you.
Thank you, Laura. It is a pleasure to share this panel with my colleagues. I'm very fortunate to call Mayo Clinic my work home and have the opportunity to work alongside colleagues as talented and committed to our primary purposes like Shira and Amanda. So I'm really thankful for this opportunity to share my insights alongside them, but also appreciate the time and the opportunity here. Shira spoke about digital health issues and opportunities. She described being specific about your goals and your why behind a new digital health initiative. She talked about the data and the digital health tools, aggregation, integration, and activation. She also discussed the unique complications of healthcare, a systems and strategic perspective. Amanda shared insights on data and research innovation. She reminded us that our health record is one of many contributors to the data we now have available that influence research. She also described how those research insights could translate into care insights. Now we're going to shift gears slightly into a different focus by looking at this topic from a clinician's perspective, specifically focusing on nursing. We'll start by looking at some of the influential factors, considerations of nursing today. Why are these important? Our pre-pandemic systems are being reevaluated by the effects and learnings we have over the last few years. These environmental factors are affecting how we deliver care and how we must implement digital tools and the use of data, as Amanda pointed out. We'll have to take a quick look down memory lane, reflecting on the primary drivers of the adoption of healthcare technology that we have today and its influence on ongoing implementation and optimization efforts. With the acceleration of our digital tools and data come from different sources. Data available to our clinicians outpace what we can effectively consume from an information and communication perspective without effective intervention. We will look at the various data sources that translate that information and communicate that back to nurses. We'll discuss these different types of information and the burden it places specifically on the cognitive load facing nursing today and how that translates to what is being communicated to our nursing staff. We'll conclude this session focusing on user experience and usability. There are many different forces of influence affecting nursing today, and I'll only mention a few. Let's start with the staffing shortages. This is a shared concern and priority when I speak to my nursing colleagues and other healthcare leaders across the country. There are several projections and statistics related to this topic. Estimates range from 7 to 20%, with increased projections into 2025 and beyond. This is a multifaceted concern and includes various contributing factors, including nursing educators and faculty shortages. According to the American Association of the College of Nurses, in 2019, there were roughly about 1,600 vacancies in a survey of 892 nursing schools. Aging faculty and salary competition with clinical practice areas, lack of resources, just name a few of those cited as contributing factors to the shortage. In parallel, the AACN also reports that we're seeing an increase in the enrollment of BSN programs by 3% over the last year, a hopeful statistics. However, will we have the faculty and resources available to educate and prepare our future nursing workforce? Will this provide what is needed for demand, and what experiences occur once nursing students join the workforce? Turnover is another contributing factor. Turnover for nursing is at an all-time high, with varying percentages cited, some as high as 27%, and all within the range of 17 to 20. According to research gathered from Epic Systems released earlier this year, from March 21 to March 22, the median tenure of a nurse with the organization has dropped from 3.6 years to 2.8 years. Demand has also increased as a result of our aging population. The work environment is also shifting, and safety concerns are being more and more prevalent. In looking at the percentage of assaulted workers in the healthcare environment, nurses are among the highest victims of those aggressions. In self-reporting studies by Mental Health America, 67% of healthcare workers cite feeling sad regularly in the last 3 months. 67%. Overwhelmingly, 93% regularly feel stressed. When we look at other words that recite positive mental health, 27% of healthcare workers regularly feel hopeful. The last factor that I'll mention is the new models of care. Nurse leaders are being asked to implement new models of care by deploying virtual solutions to meet patient demand across outpatient and inpatient settings. Shira mentioned the consumerism aspect, particularly in the outpatient setting. The facilitation of those patient visits have often placed different demands on nurses. That inpatient patient that Shira described, 9 times out of 10, is making a phone call and placing another demand on the nursing staff. In the inpatient setting, virtual models of care such as remote patient monitoring and virtual nurses are being deployed at a record pace across the country. Nurses are also seeking virtual roles more frequently and more often, and the future of nursing practice will include elements of virtual care. What are the skills that are needed to practice in this virtual world? How do our ecosystems such as education, ongoing training, and technical support need to evolve to support this shift in practice? I know this doesn't paint the most ideal picture, and how does this backdrop contribute to the deployment of healthcare digital solutions today? The gaps discussed have a heightened awareness under the current context. Under these circumstances, healthcare technology is being challenged to deliver a different digital experience, citing experiences from retail and consumerism. I'm not going to tell you that our digital healthcare solutions will solve all of these problems. However, ensuring digital health solutions don't compound or add to the current environment stressors is an emerging requirement. 2019 marked the second decade of the publishing of To Err is to Human by the Institute of Medicine. Since then, organizations have had an increased focus on patient safety and ways to continuously improve the quality of their care. According to the AHRQ, hospital-acquired conditions have seen a marked improvement over the last 2 decades. I remember when it was first published and the impact it had. I recall sitting in several healthcare technology application implementations where this article was cited during the early 2000s as rationale for implementation, and patient safety was top of the mind for implementations. In 2008, roughly 10% of acute care settings had implemented an electronic health record. By 2021, we're now looking at 94 to 95% of all acute care settings. Once implemented, patient safety and quality continue to be a primary driver for optimization efforts and enhancements. I've often been part of conversations where patient safety and quality concerns arises, and technology are viewed as the primary tools to implement the change needed. This can, at times, add to additional cognitive load and burden that comes through documentation. As Amanda cited, there are many factors that contribute to the ecosystem of data in the healthcare setting, and EHRs are one among many. The graph you see cites the volume of data in comparison to other industries. There is no doubt that we are in an age of accelerated data growth in healthcare. Where does all this data go, and how does this translate to information and potentially communication to our nurses? Let's go there next. Converting data to information that ultimately is shared with clinicians is a challenge. Cognitive load of clinicians as a result of the increased data and information that is available to them and how it is presented or communicated is a gap that we must mind and we must address. In February 2020, Collins published an article looking at the different types of cognitive load and its impact on nurses. The article describes 3 different types of cognitive load: intrinsic, extrinsic, and germane. The intrinsic cognitive load describes how much effort you need to solve a problem. Factors that influence your intrinsic cognitive load can be affected by the lack of sleep, emotions such as grief and guilt, and heightened stressors. Remember that previous conversation we had on mental health concerns for our healthcare workers on the previous slide? The intrinsic cognitive load of our nurses and the ability to process that constant influx of information is an issue that we must evaluate. We will also discuss extrinsic and germane cognitive load in the upcoming slide in the context of how information is communicated to clinicians. So moving all of that data into information and communication, where does all this data go? Expectations of our nurses to consume and process this data are present now more than ever. The extrinsic and germane cognitive load this data has placed on nursing is a constant concern among nursing leaders. Extrinsic cognitive load described in the article discusses the cognitive load that is placed on a nurse they do not have control over. So think about this. In a bedside setting, this may come from many different forms. Policy changes, updates that we are making to existing systems, or education on new ones. The third type of cognitive load is germane, which speaks to the effort required to process the information. How do these types of cognitive load factors influence communication to the clinician? There are multiple methods and modalities where the data is aggregated and presented back to clinicians. What does this look like for a nurse? There's many different modalities that you see. So you see verbal, documentation, and visual. From a verbal perspective, I have seen settings, this isn't at Mayo Clinic, but settings where nurses now walk with earpieces and headsets, and they are in the acute care settings. There's channels that they are constantly monitoring communications on, in addition to the documentation data that exists in applications like the EHR. Communication to nurses also occurs through those documentation channels and in an emergent area that includes documentation completed by the patients themselves. So our nurses and other clinicians are being at the center of the influx of all of these various data inputs and have all of this additional cognitive load that is being placed on them. Lastly, there are visual communication methods for nurses, including electronic dashboards that display information that must be processed. So if you walk down a hallway and you're a nurse, 9 times out of 10, there's an electric whiteboard or an electric dashboard that you need to pay attention to that has data that must be consumed and interpreted to meet the needs of patient care. Each of these modalities also have active and passive digital communication methods for the nurses. So where do we go from here? We discussed external factors. We discussed the cognitive load of data, information, and the communication demand increases from nursing. What is shifting? If we looked at patient safety as a primary driver for deployment in the past, perhaps we look towards usability and user experience next. This can take on many different forms. At our organization, we've elevated our user experience governance committee that sits within our clinical systems governance organization. We have included user experience as a critical component of our digital healthcare organization center. Our user experience governance committees defines user experience that includes all the users' emotions, beliefs, preferences, perceptions, physical and psychological responses, behaviors, and accomplishments that occur before, during, and after use. We are increasingly focusing on ensuring that usability principles are also a central component of not only the digital tools that we have deployed, but also those that we are planning to deploy. This may include potentially sunsetting digital tools that aren't meeting our user experience need or our expectations. Our user team looks at user research, deploying an iterative design and testing model, and the evaluation of deployed tools from a user experience perspective. We are looking at ways to multiply that effect and influence the multiple areas of governance that sits within clinical systems. We do this while ensuring that the primary value, putting the needs of our patient first, are still maintained from a care delivery perspective. I want to circle back in terms of some of those usability principles, the user's emotions, beliefs, preferences, and perceptions, and reflecting on the conversations that we've had today, both from Shira as well as Amanda. How do those emotions and beliefs work against the backdrop of some of the challenges that we're facing today from a healthcare perspective? I am hopeful about the direction our healthcare technology community, that includes our Ventnor partners, are responding to, and how at this critical time we are pivoting. And I look forward to a time when we discuss usability and user experience as a key driver for change. And with that, I'll turn it back to you.
Thank you, Edwina, and thank you to all of our speakers. We're now going to switch to a Q&A, and you're welcome to unmute or ask questions. You're also welcome to place them in the chat. We'll give everyone a minute to put their questions in. I can kick off with the first question here. But
all of you discussed kind of stakeholders, and I know maybe you mentioned scientists and providers
when you're evaluating. I'd love to just know more points from these folks,
key stakeholders.
Great. Yeah, thank you, Laura, and for the team members who asked the question. Stakeholder engagement, of course, is incredibly essential. And what we try to do is balance the maturity of the model that we're working on with the load to our clinical system of pulling in too many stakeholders at inappropriate times, right? So as models are very early in their evolution, we may pull in one or two clinicians, but as they mature, then we'll broaden that along a greater use of clinicians. So the example that I mentioned today, we're working with our hematology team. And so we right now have engaged, I think, 8 to 10 different hematologists in our particular use case that we're working on. And each one of them brings a different perspective because they see different types of patients. They bring in other experiences, having been other places outside of Mayo Clinic. And they also have different levels of comfort with data solutions. So it's not just the overall clinician to patient interaction that we're looking for, but also the actual user experience of the provider that we're trying to kind of unpack with that. So again, having stakeholders along the journey, incredibly essential. And then also, and when I shared my part of the presentation, I talked about the fact that the models evolve over time. So it's really important to not lose sight of the fact that once models evolve, to then bring that back through your stakeholder set to make sure that you haven't gone off course inadvertently.
Thank you. We actually have another question for Amanda. This is from Steve L. Do you have well-defined training sets and validation? If you'd like to go off mute and add more, you're welcome to.
Yes, but Steve, thank you. That's an absolutely excellent question. And we do have well-defined data sets and validation sets. And extensive validation and testing are absolutely required because we need to ensure safe and responsible solutions, safe and responsible AI solutions for our patient care. And so it's a very rigorous process. And we also have our compliance team well engaged as well. So for those of you who are familiar with leveraging AI tools in clinical decision support, we have to be very careful to be ensuring that as we use software as a medical device, that it goes through the compliance rigor necessary. So also showing that overall path of validation is essential to that particular process.
And Tanya, more than welcome to.
Another question I have for you, how are you sourcing patients
From
what you've implemented?
I can take that one. So in terms of looking at patient and provider feedback, again, as Amanda said, we have to be very judicial in our engagement and making sure that we're using our patient and provider feedback with pointed queries. So we ask for feedback early and often, both in terms of should we be doing these new technologies, but also how should we deploy these new technologies. So I think it's important from both of those aspects to engage your stakeholders, specifically your patient and providers in those tools. We also do have a patient experience group that we evolve with in terms of that engage directly with our patients that help us in guiding us as we deploy patient-facing technologies. Amanda or Shira, anything else you would like to add to that comment?
Sure, I can chime in with some things I've seen in other areas. I would say the patient experience one you mentioned is particularly special, and it's one I was going to mention early as far as stakeholders. With respect to pulling in the different feedback, I think the key is to make sure that you're doing it in a mix of ways and with a mix of different audience settings. So there should be both public forum and private. There should be large group settings and small group because people respond in such different ways. I think in the public forum, on the one hand, you have a chance both for that transparency, but you also have the danger of groupthink and of everybody centering around a specific comment or a specific personality that speaks up. So make sure that you include an opportunity for there to be private feedback. I completely agree with Edwina that it should be early and often. I will say two interesting things I've seen done in two different places. In one place, they had contracted with a consulting vendor who helped them in soliciting patient feedback at the very outset of the project when they were determining their strategic goals, but also in soliciting feedback from various stakeholders throughout the process. And that worked out to be wildly effective. The second tip I would give is that it's really important to know that feedback, at least in America, tends to be a thinly disguised word for criticism. And so you have to know there's the thick-skinned and receptiveness balance. You have to know that most of it's going to be suggestions and that they will automatically be contradictory. So I think two things that you can do when you're thinking about this is first, make sure to include in the questions about the feedback what's working well. That's not to make yourself feel better. That is to make sure that you don't throw the baby out with the bathwater and that you keep all of the good. The second is to try and make a metric out of every question, even if it's something where you're using, the Harvey Moon's quarter half full, red, yellow, green. It's not that it has to be a numerical data point, but something that allows you to aggregate everything will help you avoid the tyranny of the anecdote when you're making decisions about the feedback.
And Shira, if I could dovetail onto the feedback, what we're doing is just using a simple effort versus impact grid also with the feedback that we're getting. So as we're evaluating what feedback to prioritize as we're doing redesign efforts, how hard is it to implement that and how much bang for the buck are we going to be getting? And starting with the low-hanging fruit that is low investment but high reward, and then advancing to things that are a little bit more of an investment.
I have one more question. In my last job, I worked at University down in Chicago, and we were just bombarded with vendors all the time, and it was kind of hard, all of that noise. So I'm just curious how you guys kind of determine what you're going to, if you're out looking for things, or if you're kind of sifting through and trying to find things that are going to address your clinical priorities.
I can kick that one off. This is something I think about a lot because it's the question, it's a little bit of a chicken and the egg. Do you start from your clinical priorities, your strategic goals, or do you start with the possibilities and what's out there? And people tend to gravitate to one or the other. I think you actually do need elements of both. I'll give the classic answer of it depends, or a little bit of everything, but with a little bit more of an emphasis on starting from your priorities. That way you don't become too enamored with the solution. I think of it a little bit like driving. You should have a sense of what you're aiming for, your end goal, but you're constantly scanning the horizon for potential alternative routes and attractive things along the way. And so by that, in terms of putting that into real time and what that means, I think you have to, this is a part of that strategic planning. I think you have to know absolutely what you're striving for. Again, is this about margins? Is this about patient experience? Is it about clinical experience? What is your ultimate aim? You also should have a group, a person, a portion of that process dedicated to really that market scan of what's out there. And I would encourage that that be a market scan that is not limited to healthcare. Otherwise, you're confining yourself to what has already been done and offered. I would instead look at adjacent industries that have been doing things really well in digital, specifically in hospital, in telecom, in retail, especially in gaming, and see what the possibilities are and whether they could be translated. The big thing to remember is just to bring the two back together. So if you found something that's nifty and exciting with respect to a vendor solution, make sure to double check that against your clinical priorities and your strategic goals. If you are focused wholly very much and you're starting from the strategic goals, make sure that an element of it is looking at the market and what all the potential vendors are. So back to the original, it's a little bit of both, but if you have to err on the side of one or the other, make it your goals.
Yeah, the only thing I'll add to that from my perspective is that there oftentimes we do see a lot of overlap between different technologies and the deployment that we have. So keeping in mind strategic priorities and at the heart the problem that we're looking to solve for. And what are those existing technologies that we might have? What are the requirements that we have? And how does that sit within the landscape of user experience and usability, I think is something that we're trying to focus on here as well.
Thank you, Edwina and Shira. And the last comment I'd like to make on this particular topic is also thinking about talent. So talent in this space is incredibly hard to come by and incredibly hard to keep. And so what we're trying to do is look at our overall talent assets and then thinking about where do we have gaps, where do we want to build that capability, and then with whom can we partner to build that out. And in the era that we're in where we have remote work and it's incredibly fluid, we have the ability, as you do likely too within your organizations, to tap talent regardless of geographic location. And so I feel like we've been able to really kind of turn up the dial on how we can bring talent into our organization more strategically and through partnerships.
We have another question. This is a great question from Connie. How are you ensuring you are not expanding the digital divide with patients, and how about ensuring equity and inclusive solutions?
That's an awesome question. I apologize, guys. I'm going to jump in on this one. I feel pretty passionately on this, and please chime in. I think we're doing this poorly as an industry, frankly. It's something where I'd love to see a bit of progress. I can share some things that I've seen or that have happened or that could have happened, those gaps again. First, I do think when I mentioned that you should pull in that legal input early, I would include the perspective of somebody who's well-versed in ADA law, who can provide some insight into the things that should be there. I want to note this is baseline table stakes. It's not something where you can do this and then feel satisfied that you checked the box, because it's absolutely not enough. But I say that because, for example, I am technically deaf. I encounter digital solutions all the time that are actually really hard for me to access. Somebody who's blind, somebody who's in a rural area without connectivity, actually not even just rural, anywhere, and for one reason or another doesn't have connectivity, you need to be aware of what are some of the table stakes in the offering. Second, I would absolutely pull in people from whoever is heading up some of your EID initiatives or programs, your leaders in that space. I would also include the perspective of patients, a variety of different patient types from within your catchment area. I would look at what some of the others are doing. I would think a lot about investing in infrastructure. This relates a little bit to the location context-specific solutions I mentioned at the beginning of If you have something that's a really exciting solution and it relies on connectivity, and you're operating in an area that either by virtue of the patient's access or by geography that you don't have that, you may need to think about additional partners for different settings in which the patients access those. I've seen everything from kiosks to having things available at schools, at libraries, at jails. So really, I would always go back to who are your patients and what are the specific things that they may struggle with. Pull in input from regulatory, from your EID experts, and from the patients itself, and pay an awful lot of attention to the specific context in which you operate and in which you want to operate. But in general, I don't think we're doing this well as an industry. Edwina or Amanda, anything to add?
I think you described it perfectly well, Shira. Nothing to add from me.
Likewise. Thank you.
Thank you. We have another question. Stemler, what is your advice of balancing really innovative strategies or ideas with feasibility of execution when creating new digital health products?
I'll jump in first, but I'd love to hear from my colleagues on this. We very much love the idea of start small, run fast, and then scale. And so when we are thinking of, we very much work under the pilot methodology. And as we're thinking about where to pilot and how to pilot, it's not just the actual technology itself or the clinical need, but it's also who's around the table. Are they early adopters? Are they willing to be flexible with us as we go through an evolutionary state with the work? But those pilots are held to a very high standard of scalability. So as we roll through these pilots, we hold ourselves accountable for where is this going to go next and how can the pilot itself be implemented into practice, but also how can others learn from this and how can it scale. So, that pilot methodology allows us to be a little bit nimble of where we choose to land with the pilot, but it is very thoughtful and with the expectation that that is not just, the pilot's not going to end at that location, but it has to scale throughout the organization appropriately.
Yeah, I really like your point, Amanda, around thinking about who's at the table. I firmly believe, I think you need a mix of the dreamers and of the realists at the table whenever you do these. In fact, I would actually check and ask people's bent in this, because if you have only one or the other, you're going to overtilt. To my mind, it's a lot about that prioritization and pressure testing process, as Amanda was gesturing to. I personally would start with the what's possible. And so thinking about what are the innovations and then pressure testing them against then what's possible at your organization. But this does actually depend a little bit on that first question I mentioned around where on the spectrum of change do you want to play. If you're aiming for transformation, you better start with the innovative solutions and all that's out there. Maybe that's the scanning the horizon bent a bit more. If it's more about digitizing existing processes, you're automatically going to start a little bit more with the pragmatic bent. But I think the general through line is that if you have a list of the different ways in which to play, essentially the different potential solutions, I would prioritize those. And whatever it takes to get there, 2x2, red, yellow, green, scores, you name it. The thing that I would say is that if you don't know what you're not going to do, you have not prioritized. So everybody should be able to name that. So once you have those priorities, I would suggest pressure testing the top three, much like what Amanda was saying around pressure testing. And by that, I mean, I would look at the operational, at the financials, at the regulatory. And one thing that I think gets skipped a fair amount is this, Amanda was mentioning scalability. So when you look at the different potential pilot sites, I would double check that they are not the one and onlys. So if this is something that will work really, really well in one clinical specialty or another, what is the plan for the second and the third wave to be able to scale? I say that because something I've seen in a few different organizations is fantastic solutions that work for 3 different specialties or departments. And then there is not the wherewithal, the resources, or the technology is inappropriate for the rest of the organization. So that's one of those pressure test questions that I would always ask yourselves, which is, will this work for a broad enough swath of my organization to be able to achieve my strategic goals?
Yep. Just to add to both Amanda and Shira, that concept of the pilot is really important in terms of its ability to be light and agile. However, oftentimes the reality is sometimes those pilots aren't light and agile. And as a result, that gives us the pressure testing that we are looking for from Shira's perspective to say, how scalable is this solution truly? If it's taking us 6, 8, 9, 10 months to deploy this in one area, what's the feasibility of actually getting this out across multiple areas and multiple. So that's the only thing that I would probably add to that question. It is definitely a balance in terms of not only looking at innovative strategies, but also what you can consume from a technology talent perspective while they're also supporting existing systems.
You know, I was just thinking, this question makes me think back to that example that I shared at the very beginning around a hospital system that we worked with where the C-suite had the bold vision, operational leaders on the board all had different, right? I actually thought at the end of the day, it was a little bit of a shame for the system, and they ended up with a solution that was great for them. So really hats off and kudos. But it was a bit of a shame in terms of thinking out to 10 to 20 years. I think that the C-suite had actually a pretty innovative vision that would have taken them in a pretty transformative direction. And the thing that held them back was that it was feasibility, but it was feasibility from what we know today and what we have today. So I think when you think about feasibility, there has to be a broader lens on not only what we have today, but what we have at today that we can build toward tomorrow. What are the resources, the creative partnerships, the model that we can start small and build big? Because if you only start with what's feasible today, you will always end up on the digitized piece of the transformation spectrum. And again, that's just fine, but that may not actually meet your goals. So I would think aspirational as much as possible, but you can tell where I sit at the table. I too tend to be on the dreamer side. So I think you should be real about what your bent is and make sure you're talking to people who are the opposite.
All right, I think that that's all the questions that I'm seeing. Is there any last minute questions from the audience? Will there be a follow-up session like this? I think maybe what you're referring to is potentially our virtual discussion. So if there is any questions that you have post today's event for our speakers, we invite you to share that on our virtual discussion where we can have an asynchronous just a discussion and the speakers can answer there. So if you are watching this as a recording as well, you can also engage with our speakers post.
I would encourage folks to ask the questions now if you have them, simply since you have. I've got to say, I feel very honored to sit next to Edwina and Amanda in this room. So don't be too shy. I'm actually super curious, for example, what others have done, for example, in equity and inclusiveness for their digital health solutions. I'd love to know from Amanda where some of the new kind of exciting horizons are in the research space. I'd love to know from Edwina, what are the things that have made the most difference for the nurses in different arenas. It feels like we have the time, but we can also close if people don't have questions.
Well, sure, I'd be happy to weigh in a little bit on some of the other things that we're starting to kind of just scratch the surface on from a research point of view. You know, with these digital tools at our disposal, we have the ability to have such a broader level of access and catchment with patients, regardless of their location and their ability to come for care in a given physical space. So what that is also doing is it's really opening up the lens for who can be included in clinical trials and how can we get, you know, really tip of the spear care to these individuals when we're in more of an experimental state. Now, as I shared earlier in my presentation, sometimes the clinical question or the desire is really out ahead of what the infrastructure is. So even though we have, you know, digital solutions, maybe we don't have a way to capture labs and get the lab and samples transitioned back. So not only are we looking at the digital ecosystem for, access to patients and inclusivity of trials, but we're looking at the overall infrastructure for delivering results and contact with patients, et cetera. So, but what's really exciting about all of this is that we're making these steps forward and getting people excited about that so that the other aspects of the ecosystem that need to catch up are getting the attention that they need.
Sure, I'll just add in terms of your question, in terms of nursing impacts, when I'm rounding and I'm talking to our bedside clinicians and our frontline staff, I tend to ask them a few questions. One is, what are the you most likely use? What are your go-to tools? And the second question I ask them is also, what are the tools that you could take away? If you could take away some of the digital tools that we've implemented, what would that be? And I think in terms of areas of impact, that is what we're noticing, especially in the post-pandemic world, is what are the technology and tools that are absolutely critical, that are making our lives a bit more efficient, and what can you perhaps ease, take away, reduce, and how do we aggregate some of those disparate silos and technologies that we have today in a meaningful way for our clinicians. So as I round and as I talk, that's primarily a theme that I hear from our nursing staff.
Edwina, I love where you went with this. In the digital space, it's so easy to get digital clutter and to get mind clutter. And so, and it's so much easier to say yes than no to things. So I really appreciate your comment and that rigor required to say, all right, as we move forward, what else can we declutter in this whole space? So
yeah, I love both those comments. It actually makes me think there's another element of this for both the clinician, nurses, physicians, and for the patients, which is how do we provide transparency around what people will encounter when and what they can expect as far as timing. I say that because, for example, patients do much better in both bricks and mortar and especially actually in the virtual world, which feels a little bit more opaque when you're sitting in the ether, to know where in a given visit they are. And this is where we can see lessons from other industries where different, especially in the retail world, looked at things like Lyft and Uber and the ability to track, and also in shipping and receiving. And so therefore you could track a car. Similarly, you can track a patient from the clinician's perspective, and a patient can track where they are in the visit. And Amanda, I have to imagine that there's something similar as far as providing transparency with respect to the research flow, right? And so when I think about if we try to provide that framework and that visibility to each stakeholder within a given process, I wonder if in mapping it out, you would find all of the different vendors, all of the different data inputs, and you would see some of that clutter, and you could be able to streamline it a little bit. Looks like we have a question.
Can you all hear me again?
Yeah.
Yeah. Wonderful. Yes, we have another question from Megan Koffenberger. What tactics have you used to make care seem care?
Health digitally and also receive care in person.
I think the starting place for that is make sure that the tools that you're using for both are similar, or if not the same. So if you're using certain tools in terms of remote and virtual world, try and use similar documentation tools and make sure that there is interoperability between both, so that the data that you're capturing in the virtual world is the same in the hybrid world as it is in in-person care as well. I think some of the other ways in which you can make care seamless is to apply the same principles in terms of your values and your beliefs in creating that digital experience for the patient in the same way as you would in a in-person care setting, and making sure that the clinicians are well versed in how to deploy that virtual care in a manner that's consistent with your core beliefs and expectations. So those are two that I would offer. Shira or Amanda, anything you would add?
Yeah, I love that, especially the point about interoperability. The thing I would add is this is where mapping from the full experience can really be a lifesaver with respect to both clinician and specifically the patient, since you asked about that, Megan. And by that, I mean, if the patient is entering, as it were, is being referred into or brought into your department, your network, one way or another, I would think about what is the handoff in terms of the information that comes in, either that they're bringing in or that's coming in through a vendor. Something I think a lot about, for example, is wellness and other sorts of digital providers that are wholly digital that then offer a referral in or other means that the patient starts to enter a traditional provider care network. And if you can think about what's the information that comes in and what information is needed and how can we shortcut this for the patient, that means that you don't have the patient then filling out intake that replicates things that they've already done. Similarly, if you could think about it within your provider organization, I would think about mapping out cross different department flow. Too many times I've seen different organizations say, we're going to do digital health for neurology, for CV, for cardiology, and you come up with a really wonderful solution, but you don't think about where the patient is coming from and where the patient is coming to. So if you can map all the way from beginning to end and note what information is available when, so that you don't have that replication and so that you can make things a little bit more efficient, that greatly helps not only the patient, but the providers. Last but not least, I would second what Edwina said very much around do make sure that you're thinking about the forms and the EHR inputs as well as the vendor inputs. And I would add to that, and this is more from the legal perspective or just having been privy to various different deals, it is so easy when you're working with a vendor for one side or another to say, we can give this data or we can't, or this is just ours. I would push on that a little bit and explore the business goals. I say that because I think a lot of times you would find that, oh, actually a vendor can give you the data in aggregated form, or there's a way to release it, and that can greatly help you with respect to that patient flow. So be a little bit skeptical. Amanda, did you have something you wanted to add there?
No, thank you. Excellent answers.
All right. Well, I think we can wrap up then. Thank you to Mayo Clinic for all of you for speaking today. Let's see if I can advance the slide here. This is an upcoming telehealth immersion program event. We're doing it in partnership with the American Telemedicine Association. It'll be using our Value of Virtual Care framework, and that'll be on September 23rd, and registration is available on our website. Additionally, we invite you to join the Physician Innovation Networking platform for providers and entrepreneurs, so healthcare startups. And we host discussions. We have one for the telehealth immersion program. It's a Q&A. So if you didn't get a chance to ask your question or still have a question that comes up maybe tomorrow, you're welcome to log on and ask the question there, and we can surface it to the presenters. I'll give you a second if you're following the. Additionally, if you have any other questions or want to know more about the program, you're welcome to reach out to myself or Bernadette Lim. And thank you all so much.